Bueno, we roll. Well, everyone, how are you? Gabriel here, Ground Up Academy, and today I have a special guest, a friend of mine, Dr. Joaquin Fernandez, a foot specialist. And we're here to talk about all the related injuries that we get from working out and the foot, Achilles tendinitis, heel spurs, and we'll also go into a little bit of other dysfunctions and also injuries that you get in your foot. Also including obesity. So we're going to throw a little bit about there, but primarily on Achilles tendinitis and also foot spurs. So introduce yourself. Tell us a little about yourself.
Hey Gabe, thank you for having me. It's a pleasure. And hello all. My name is Dr. Joaquin Fernandez. I'm actually a podiatrist, a foot and ankle specialist. I trained in South Florida, then finished my residency there. I just recently completed a fellowship in Cleveland, Ohio, which we're here now, at University Hospital's Medical Center. My fellowship was more with limb salvage surgery, with amputation prevention and wound care and infectious disease. But sports medicine is also a subspecialty field within the podiatry world, and it's a common group of patients that we see in the office, private practice setting, and sometimes we have to work with our athletes in the office and oftentimes in surgery as well.
Oh, that's very good. That's awesome. So like now, when you get into the knife for surgeries, it's you, let's say for the foot, and do you also work with another doctor, like a neurosurgeon is there ever?
Not a neurosurgeon, and it's so funny you ask. For instance, my uncle is a neurosurgeon, but well, he's a neurosurgeon in Germany. No, not so much. I mean, we're friendly with all medical staff and personnel. That's one specialty we won't do. Neurosurgery, and if you don't know, it's surgery of the brain.
But I thought that when you have a neurologist, let's say you're working on the foot, and you are doing a procedure that's close to the nerve in the foot, you don't have a neurosurgeon there?
No. So
I got operated and I had one. They had the otolaryngologist, what do you call it?
ENT specialist.
ENT, and you had the neurosurgeon there because they were going very close to my nerve here.
Mm-hmm.
So they had him there present.
So for us, our surgery is from what's called the tibial tuberosity, which is just right below the knee down. So any surgeries related to the foot, structures that govern and function of the foot, as well as the leg, whether it's anterior or posterior, like an Achilles tendon surgery. So oftentimes we not get confused, but it's almost like orthopedic surgery. An orthopedic surgeon specialist is in their residency. They treat hips and knees and shoulders,
okay.
And knees. For podiatrists, we treat, as I mentioned, right below the tibial tuberosity, so the leg and the foot. However, during our rotations, depending on the residency program, you have a dedicated month of being a resident with orthopedic surgery, or your orthopedic surgeons are also our attendings as well. So even in residency, I got to work with them extensively, and to get surgical experience, so I would help with, or any of us would help with orthopedic surgeries and hip cases and knees. To go back to your question about neurosurgery, so with the nerve or any disorders of the nerves, we often consult a neurologist specialist with the disorders, anything that we suspect with neurological conditions of the lower extremity.
Yes.
Is it feasible for a neurosurgeon? It could vary by the hospital, or let's say in the rural setting. But from what I recall, a neurosurgeon is more with the actual brain itself and the nerves of
of course.
Of the face.
I mean, the brain and the nervous system is the communication to the muscles for movement.
Mm-hmm.
I mean, that's always there. Because you got the nerves on the foot, you got the nerve receptors, the nanoreceptors on the foot that tell the brain where you're standing and how the surface feels, of course. So I always, I'm asking because of that. There's one thing also when I make people work out, I make them work out in many exercises, or some specifically, like for example the deadlift, using it barefoot, so they can start recruiting the nervous system in their foot, and they start feeling their anatomical precision better, which translates into having a better mobility, because a lot of the times that does happen.
Oh yes.
But this is in the movement base.
Mm-hmm.
Now, more like tissue and more into real surgery like yourself, you're going in there for correcting and curing something that the holistics didn't work, right? Am I correct?
Yes.
Okay, so let's go, now that we're here.
And then, do you want me to do with the nerve? I think I know where you're...
yeah, tell me.
Sure, yeah, absolutely.
About the nervous system.
Yeah, no, absolutely. It's all integrated. And so, for instance, oftentimes the patient will complain of numbness and tingling, a burning, shooting pain, and after we do a thorough history and physical and assessment, it can certainly be related to an injured nerve. There are different classifications. Sometimes even in the heel you'll see it's due to a compression of a nerve. There's also what's called tarsal tunnel syndrome.
Tarsal tunnel syndrome.
Yeah, which is in like the inside aspect of the foot, tingling, and often that
so it's in the inside, the tarsal tunnel, so it's on the medial side of the foot.
Correct, medial.
Inside the medial side of the foot. And tarsal, what's it called?
And the tarsal tunnel syndrome.
Tarsal tunnel syndrome.
And as Gabe mentioned, it's the medial, which is the inside of the foot. There's a major nerve, it's called the posterior tibial nerve, that runs right on the inner aspect of your ankle. Patients, let's say a flat-footed patient with the collapse of their foot there, that way, is compressing on the nerve itself, and over time it becomes thickened. Or I should specify the muscle tissues around that area get thickened and it compresses, and it's as if it's strangulating the nerve, and then patients will have a numbness sensation.
So the muscle, so the posterior tibial nerve, that comes originally from the sciatic nerve, or no?
It's a branch, yes.
It's a branch. So the posterior tibial nerve is a branch out of the sciatic nerve, which is one that we do talk a lot about because it's a big nerve, the sciatic nerve. Okay, so it's a branch, and it runs after the sciatic nerve. It goes behind the tibia, or
yeah, it runs like on the inner aspect of the tibia, and then it courses
like
down
around the bone. So, so behind, in between the bone and the tibia.
Yes, and some tendons, major
Some
tendons.
tendons. Okay.
And you also have your arteries and veins there, but you have your major tendons as well that are structures that come from muscles in the back, posterior aspect of the leg. Like tibialis posterior and flexor lucis longus, as well as your flexor digitorum longus, are all structures of the posterior aspect of the leg. And so for surgery, like a tarsal tunnel release, you know, if as a specialist, it's a type of surgery that we don't necessarily need a neurosurgeon for that.
Yeah.
So we can go ahead and release, and it's called a release because of those structures that are around and compressing that nerve. We can go ahead and release and give it more of an evacuation in order for the nerve to breathe better.
Okay.
And then there are also some grafting options too. If we see that the nerve is completely friable and degenerative, we'll go ahead and do a graft augmentation.
What is a graft augmentation?
So you have different grafts that work as a conduit, and it's basically...
Sorry, it's graft or grass?
Graft.
Graft.
Yeah. Different types of graft, like it could be usually an allograft, which means it's a graft coming from still like either from a cadaver, the same species, but not necessarily from yourself. That would be like an autograft, for instance.
Okay.
And then you have a xenograft, which is from a non-human species, like an animal.
Okay.
Patch or something like
So
that.
you get something from another animal. Good.
Yeah. Sometimes, we need their help sometimes. So.
Where usually, sorry, out of curiosity, what animal usually is this, if you know, or is it?
Usually
another mammal, right?
Yes. The common xenografts, and they run, either like in reconstructive surgery or also very popular in wound care as well.
No, but what animal does it come from?
Oh, sure, yeah, it could be from cow, bovine, also from porcine, a pig, submucosal intestinal
Submucosal
Yep,
intestinal.
yep. Mm-hmm.
Submucosal intestinal.
And then there's also some with shark cartilage as well. And then with,
I was going to say that shark. Unfortunately for the shark, there's so many medicinal properties from
yeah.
like so many. It's like the cure animal. It's like the cure animal. It's a holy cure animal.
Absolutely.
But it's so hard to get sometimes,
Yeah.
especially in the United States.
Yeah.
Yeah, a friend of mine. Yeah, going on to that friend of mine. He got pure shark omega, and it was from a pharmaceutical company in Israel. That he told me that shot of pure strong shark omega was not sold in the U.S. He got it from a friend that brought it from Israel, and then he gave it to clandestine physician and shot it, and then immediately healed up in seconds.
Okay.
His standard doctor said, his original doctor said, "Nah, you can't. You did this illegally. Get away. Get out of my office." But it worked. He broke his radius and his ulna, and it went like that. And then what would have taken about a year, it healed up in 9 months, and it healed up better.
Mm-hmm.
That's what he said. This is what he claimed. This is not clinical study. This is what he told me out of what he saw. He's broken a few bones too. He was a skater, extreme rollerblader. So injuries one after another. Okay, so where were we? Yeah, so we were about the animals, and okay, cool.
And some, and some grass are human as well, derived from
cadavers or donations.
They're correct tissues as well, or cadaveric. But then also free living tissue cells and cultured cells from placenta, human umbilical cord, and neonatal division. So that's also.
So out of all out of problems already in the nervous system and receptor, the neuroreceptors in the foot, already automatically the person should have malmovement with the legs.
Yes, that is a predisposition. So a whole another aspect of the lower extremity is biomechanics. And it's all related to the gait cycle, which means basically how an individual walks, and the steps, and it's all tied, it's all connected. So this is why in medicine, the body, the foot is still part of the foot, and it's all connected, not just the nervous system and your vasculature, your cardiovascular. But it's related to the motions of your knees all the way to the hips and your back. If the patient has scoliosis or dropped shoulder. Even though we have to treat the patient for the lower extremity, we still have to see the patient as a whole, because that's often related. Yeah. So we have to work extensively with other colleagues. And oftentimes, for instance, if a patient has an ankle issue, it could be related to their hip. So they will have like the hip fixed, and then the knee, and then the ankle. So
kinetic dysfunction.
Correct.
Kinetic dysfunction, kinetic injuries. And then what we say is once you start with one thing starts dysfunctioning, the others start to go little by little, and then there's repetitive movement, and then pain, and then leads to injury. Yeah. So
weakening, imbalances, and then for people like ourselves who are athletes and the community out there for you guys, you'll have those you'll be prone to overuse injuries, and it could become worse.
Yeah. Over the time. Yeah.
And I know,
it goes down the hole.
Yep, and us as the athletes, we don't want that, because then you're out for, let's say, a season. And in addition to that, then you're also,
or maybe if you don't look at it, it can make your career go shorter. Like it happens to many athletes who are they make a ton of money. They make a ton of money, but then they're pushed to keep on going because they have their manager, or they're being pressured, or of course they have the lion heart. They want to get that gold. So it happened to, for example, the athlete out of my head, Di Maria from Argentina. He played in Real Madrid, and he had one ugly injury in one season. Then in that season he had another ugly injury. Then he did the World Cup, and from those injuries he didn't recover. He had another ugly injury in the World Cup, and then that's it. They took him out of the big leagues, and he's not big leagues. He's still Manchester United. It's a big team, one of the world popular ones.
Oh, yeah.
But in comparison, coming from Real Madrid, which is the top teams in the world, it's going back. Too many injuries. He didn't take a year off and then go back in, which is very hard for athletes to do. Getting out of the game and coming back in a year, it's really hard. The only athletes that I see doing that take maybe a year off are combat sports athletes, boxers, MMA, because their leagues are more stricter when getting back in the game, because they have to go through a physical, and there is a limit. There is a limit of how injured you can go into the sport. You know, if you have a head injury, neck injury, and the doctor says if you get a punch, you're most likely gonna die in the ring. No, we can't let you fight. So they got something like that. Okay, let's carry on. Let's go back to the foot. All right. So malmovements and kinetic chain dysfunctions lead to the main cause for Achilles tendinitis, and then also some people say heel spurs. So what is the difference between a heel spur and plantar fasciitis? Because sometimes we think that you get a heel spur first and then plantar fasciitis, or plantar fasciitis and then heel spurs. So they're related somewhat, but not necessarily. So tell us about that.
Sure. So plantar fasciitis is probably the most common condition we see in the office. A patient will come in and not necessarily an athlete, but oftentimes an athlete. They'll complain of
athletes
heel
mostly,
pain.
if when you ask them what activity is it that they're doing that they think is, I think it's running. Running is I think is the one that would get the most plantar fasciitis.
New running or something. We'll ask the patient with their history and physical. You know, what do they get new footwear, or they started a new activity that they're not used to. And it's inflammation basically and thickening of the plantar fascia, which is underneath in the bottom of your foot. But it's running also from the fiber attachments from, actually believe it or not, from all the way from your Achilles tendon. And that complex is also combined with the back part of your leg.
Yeah, we call that did we just say the posterior fascial line, because they all interconnect with one and the other. So that's the way we look at it in the fitness world. Because always where one muscle or one ligament or tendon ends, another one starts. So they're all interconnected. I also was looking a term that the fascia line, there's 3 layers, right? So you have the foot, you have the plantar fascia, you have one in the middle, and then you have a little one that's called the spring. What are those?
Well, the band itself, it's actually 3 compartments. You have your central, you have your central band, your lateral, which is your outer, and your medial band. The spring ligament, that's a different structure. That's
more on the inside.
It is still in the inside. It's deep in there. Yeah.
It's on it's on the calcaneus, and it connects to the calcaneus and to the.
Yep. It's the plantar calcaneal navicular ligament.
And what's the one in underneath that? Because there's now you said there's 3 going, medial, center, and then lateral. So and underneath those, there's not 3 of them, or those 3 they basically stick out.
Well, okay, so now I mean
they stick out and like.
No, they're different. Like there are a lot of muscles and.
I'm not testing you here.
Yeah, no.
Conversating nerd terminology here.
Yeah. No, on the bottom aspect of the foot, there are different, like 4 major layers of the foot that runs from the bottom, and it's something that even as we dissect, there's the first layer, your second layer, your third, and your fourth layer. So, for instance, in your first layer, you have like different. Each layer has different muscle structures. I could list them all, but for instance, the first layer is your abductor hallucis muscle, which is a muscle that's in the inner portion of your foot, your flexor digitorum brevis, flexor digitorum minimi, and then, for instance, in your second layer,
flexor digitorum minimi, and
that's on the
flexor digitorum. How do you pronounce that? Because I pronounce it.
It's called. There's one brevis. Yeah. So it goes from like inner aspect, central aspect, and then an outer aspect, which is lateral.
Gotcha.
and then your second layer, then you have what's more deeper around your plantar fascia, your it's called quadratus plantae muscles, as well as your lumbricals, and then you have two major tendons as well.
Speak a little bit louder.
Oh, sure,
yeah.
sure.
So a little bit louder. Okay, say that last part again.
And then also two major tendons as well.
Okay, got it. Okay, so back to Achilles tendinitis. So the most common cause of this, they're saying, is the kinetic dysfunction from the upper body. That's what they're saying. So runners get it. Let's say they don't have what we say a muscular imbalance that causes mal-movement, mal-kinetic chain movements. So runners, do they get it from, of course, frequent impact and overuse? Because runners have the problem of getting tight Achilles.
Yep.
And then the foot goes with it, right?
Right.
And then from there, it could either cause Achilles tendinitis or plantar fasciitis.
Correct.
Both of them can be triggered at the same time, but which one goes first? I think it's Achilles tendinitis before you get plantar fasciitis, or is it plantar fasciitis?
So they usually, from what I've seen, it's one or the other. Related to the dysfunction, it's called equinus contracture, which equinus means it's thickening of your Achilles tendon in the back and your muscle groups in the back. So you have a thickening, a tightening rather, of your heel cord. That's the terminology for it. And once that is thickened, it limits what is called your ankle dorsiflexion. So pretend this is your foot and your ankle going up, dorsiflexion is up. So as you're not able to have like a full range ankle dorsiflexion of like 90 degrees.
We call that, you get bow feet. So literally you get the mechanics of a bow and arrow. So you got the bow here, and if you put a string from here to here, you can shoot an arrow right through, because it creates that tension. You get the bow feet. Bow feet, meaning that the calf. We generalize the calf and this Achilles and then the soleus as creating bow feet. But most of the time, when I get clients with very tight lower legs, the foot is also very, very tight too. I mean.
And that's related to the equinus contracture, because, for instance, with your posterior aspect, not just with your Achilles, but a tight, your gastroc muscles, your two muscle bodies there, can also be tight. And sometimes we have to differentiate, what is it due to the tight gastrosoleal complex, or if it's not, or is it due to an actual tight Achilles instead. So yes, it could be due to, for instance, like a gastrosoleal complex, so it's related to the gastroc and the soleus muscles. Or a tight Achilles. And with that, as Gabe mentioned, with that tightness of your posterior leg and posterior tight calfness and or tightness of your calf there, it does lead to plantar fasciitis, because those fibers, as I mentioned earlier, coming from behind on the bottom of your foot from your calcaneus, it's a pulley system. It's a tug of war. So your leg is tight, like kind of like a bow and arrow, and it's pulling the fibers from your foot from the plantar fascia. So then the inflammation is basically because it's shredding those fibers apart, and then sometimes we'll have a thickening as well of those fibers, and they get weakened, and then it causes an inflammatory response. And related to the heel spur, from the origin, what we say is coming from the plantar fascia, comes from origin from the bony prominence of your calcaneus there, and it's pulling on it, and literally it's shredding that bone apart, and that's pretty much the inflammation that patients will have, and they'll have that pain right there in the medial calcaneal tubercle. Medial, again, the inner portion, calcaneus, your heel bone, and tubercle is just that part of the bone. So with the bone spur, we'll have a patient have x-rays. Believe it or not, and this is something we explain to patients as well, and I'll explain to the community as well. We could see a bone spur that's there. It's the inflammation of that of the bone, but it's basically that overgrowth and that pulling from the fibers on the bone, and over time it gets big. But a patient can have that and not have plantar fasciitis, or vice versa. A patient has plantar fasciitis but there's no bone spur whatsoever.
And how does a bone spur feel? Like, is it a pinch, or is it, or the patients complain that they feel it all over the foot or all over the ankle?
More so it's this focal pain to that area, a soreness, if they have some burning.
On the bottom of the foot, or like around the whole foot?
On the bottom, not if it's the whole
Close
foot.
in the calcaneus area,
Mhm.
so in the heel area.
In the heel area,
Yeah.
in that
Okay.
inner part. Now, if it's completely in the back aspect of the calcaneus, we have to rule out if it's completely posterior heel, then that could be something, for instance, like Achilles tendinitis. But if it's more towards the inner aspect, then we're more suspicious for plantar fasciitis as well,
Got it.
or instead of.
So what to differentiate a spur and plantar fasciitis? What do you do? Is it an X-ray, an MRI, or is it a physical assessment, a touch?
Physical assessments, X-rays as well will show whether or not it has
Sorry,
a
my
spur
phone
there.
is sounding.
Physical exam would palpate there. We also do percussion to rule out, for instance, your a tarsal tunnel syndrome. That's that could be. We have to rule that out as well. And MRI, it's not the first line of treatment. If anything, in terms of imaging, it would be, if anything, the X-rays. If it's something that's recurrent, or even after conservative options, or even, let's say, if you take a patient to surgery, then you may consider an MRI to rule anything out. That's not leading you to suspect for plantar fasciitis. But we'll have our patients, besides resting and icing will help, to calm down that inflammation, a compressive wrap as well, elevation too.
What elevation do you mean?
Like just keeping, let's say you're an athlete, just keep your leg up, that'll help decrease any inflammation and swelling.
Okay. And then cold and hot treatment.
Mm-hmm.
Cold
Or
and hot
also
treatment.
cold for plantar fasciitis. And we'll tell patients to use an ice pack, right? 20 minutes on, 20 minutes off.
Ice buckets?
Ice pack.
Ice
Yeah.
pack.
Mhm.
I mean, when I mess up my ankles, or sometimes my feet get sore from
Mhm.
working out because I use minimals or barefoot, and I do MMA and jiu-jitsu, my feet get inflamed. I just go with the ice bucket while I'm watching TV.
Oh.
I hold as much as I can because it sucks.
Yes.
And it really sucks. It hurts, and then I get it out.
Yep.
And then I put the other foot in because might as well do the other foot in, or just both, because the cold triggers calcification and collagen synthesis. So it's the regeneration of skin and bones. It promotes that. So I do that, and it's good for your feet, of course. Cold treatment, cryo treatment is good. So going back to that, the heat is important because it's for the muscles more. So it triggers protein synthesis.
Mm-hmm.
So that's why hot and cold, they go with each other. So it's better to go with the heat first. Get the whole time you need it. It's about approximately, to get the benefits, they say 20 minutes at 140 degrees. That is a lot. I feel that it gets good, or starts to get good, 30 minutes. Or cumulative 30 minutes. You can do 5, but cumulatively. And then you feel the big difference the next day. And then, of course, after, followed by, I would say, an hour later, to allow the heat to take place for the protein synthesis to settle in, fall in, and then the cold. 30 minutes with ice. If you do cryotherapy in the chamber, it's 3 minutes. Or if you want to do the whole body, they say 30, which is ice baths, which are brutal. I think it's a test of might for people who do it, and it is. Okay, so we're talking about that recovery.
Sure. So other like conservative treatments for plantar fasciitis, when we see the patient in the office, we'll give them different options.
What about a medic? Sorry to interrupt, but one before I forget. Any electromagnetic pulse? You know how you put the cubes in and it sends the electromagnetic pulse? Does that help plantar fasciitis? Or is
it can, but it's not first line of treatment.
Okay.
Sometimes we'll have to refer to a physical therapist. But prior to all that, a patient conservative treatment before any advanced modalities, often all they need to do is stretching or a short course of an anti-inflammatory, a solo medral dose pack, steroid pack for a few days. Often that'll calm it down. There's bracing. There's what we call it a night splint, because as we explained to the patient that it's related to that equinus contracture. So basically,
so the bow feet.
So
when you get the bow feet and it gets really, really bad, after you get bow feet, that's when you get.
So a night splint, if a patient wants to wear it for a night as we're sleeping, because when we're sleeping, we're completely relaxed. And plantar fasciitis, the patient, will ask, when is your pain the most? And it's usually worse in the morning, the first step in the morning.
Okay.
As we're sleeping, we're completely relaxed. So the ankle is pretty much in a plantar flex position.
Flex position.
Yep. And then when you're attempting to wake up again,
the fibers
it gets like.
And then you need to separate them. Okay, so when you get tightening of muscle fibers, severe tightening of muscle fibers, there's no. When I go like this, I'm doing the actin and the myosin, which is a muscle microscopically. So they go like this. You have thousands of millions of them working together, all interconnected. When you have excessive tightness in the muscle, the myosins and actins are stuck together. And what happens? There's no circulation going through. So there's no blood. So it hurts. So getting SMR, foam rolling, stretching allows fluid to go in, massaging also, trigger point therapy, which takes the tense spots away. That works. Okay, so the night splint, it's like a compression sock that holds the foot in dorsiflexion?
In dorsiflexion, you got it. Yep.
Okay. So it's
So it's almost retraining your.
So it's plastic. It's almost like kind of like those plastic casts that you're using.
Yeah,
it's like a brace.
It's a brace, yes.
Okay.
And there are different companies and versions, but ultimately there's like a plastic portion and then like a foam felted crossover and Velcro. For instance.
And it doesn't cut their circulation while they're sleeping.
No, no.
Okay, good. Very important. Very important. Yeah. So one of the big pains, also signs of plantar fasciitis or spurs. So you see tightening in the lower leg that leads to the foot, and then when it gets severe, you start feeling numbness, pain when you wake up and start moving the joint area. Start getting dorsiplantar flexion. It's hard. And what else? We already said that you feel numb. If you feel numbness and tingling, it could be a nerve disorder.
Correct. There's also a post-kinetic dyskinesia, which basically means pain even at rest of the foot. So you're still having that pain and soreness that you feel at the bottom of your foot there, even while at rest. So it's not necessarily even during activity. You'll still have that pain. Actually, I myself, I had it on my right foot as well.
You told me you did a treatment on yourself. The foot doctor got doctored.
Yeah. So I stretched more. So even before, I actually, I didn't get the night splint, but everyone's different, and depending on the severity. Another, what we also offer is a steroid injection. Which will calm the inflammation. I eventually did, and actually that cured it.
What type of steroid? Because in the fitness world, we know about steroids. And I've never done steroids, only for medical treatment for myself that the doctor gave me, but I've never taken anabolic steroids. And knowing bodybuilders, friends of mine who have done it, because that's the name of the game in that world, and in the athletic world, a lot more than what we think. There's different types of steroids. So which type of steroid is the one that medicinally was used for your foot?
Usually we'll do Kenalog.
Kenalog.
Yeah, Kenalog.
Kenalog with a K?
Yeah, K-E-N-A.
Kenalog steroids. Okay, so it wasn't. Yeah, it looks. And that one only. What it does is promote. It basically promotes taking inflammation away, or does it have some anabolical effect to the muscle?
I don't think it's the inflammation.
The inflammation, okay. So it just speeds up the healing process.
Yes, correct.
Okay.
And for oftentimes that'll just nip everything in the bud, so to speak.
Got it.
Patient. It worked for me, but it doesn't work for everyone.
That would be better than taking a cortisone shot.
No, I mean, no, it's I mean, we often pair it also with the solumedrol dose pack. A patient will then take,
What's
anti-inflammatory.
okay, solumedrol. So cortisol. Am I saying it right? Cortisone.
Yes.
Cortisone would be something for bone, not for muscle tissue.
No, I mean, I mean, basically it is a cortisone shot, but the ingredient oftentimes the most common one that we'll use is a Kenalog.
Kenalog. Okay, good. Okay, so let's take that out of the way, because sometimes, since excessive, I mean, your body produces cortisol.
Correct.
And it destroys to reconstruct, and it also uses to construct. So it's a hormone that's very.
And we have to
important.
balance it.
out. Yep.
Yeah, we can't overdo it, and we have to give a span. We can't 3 shots to a year. So if you guys please don't be like go to another doctor and keep getting shots and shots, because that's actually making it worse.
It's making it worse, and it's going to affect other areas in your body. It's going to really hormones are something that affects everything. It doesn't work in one area, it goes to the whole system.
Yes.
So if you shoot it in your hand, it's going to affect everything else. And that's something that our body produces naturally. Our body produces it a lot also when there is an injury, and also when you have a strenuous workout.
Yes.
And that is also being looked at a lot, and it's getting around into burning fat, because it works also with the testosterone and the growth hormone all together to go after the energy reserves. Fat. Okay, so back to the heel. Okay, so we got that. So the treatments for it could be steroid,
cold
and hot treatment, massaging, and stretching.
So like your runner stretch. So basically any stretching exercise that help strengthen and try to correct for that, what we mentioned earlier, the equinus contracture. And this is something that's very hard for patients to do. Life goes on, you're busy at work, at school, kids, relatives, trips, family, I mean, it's life. So
I say about stretching, if you're watching TV, that's the moment to stretch.
Yes.
That's what I recommend, friends, clients, to stretch.
The band or the towel.
The band or the towel. Do 2 things at the same time. And also put a timer so you can know how much time you're stretching. A thorough stretch should be a minimal of 1 minute. I know there's in the basics of exercise physiology, they go by the stretch starts to happen at 20 seconds of holding the stretch, which we call, which is the Golgi tendon organ tells the muscle relax, and then it starts elasticizing. That starts at 20 seconds. A lot of the times you have trainers and instructors only making their clients and members stretch only for 20 seconds. And then people have this misconception of only doing it 20 seconds, that's all you need. At 20 seconds is when it starts. If a muscle is very, very tense, you need to do a lot more until the tension goes away. I would say minimum 3 minutes if it's a lot tense. And then for me, once a week I do a full body stretch, 5 minutes. Now I do it in the day that is, let's say that if I'm taking a break on Sunday, I'm not working out, I do it on Saturday, because holding the stretch for 5 minutes also breaks a lot of tension and also breaks the tissue to be elasticized. So basically your muscles are going to recover in up to 48 hours, meaning Monday you might still feel it because you had a lot of tension, you broke it down, but you took away that tension off. In the future you're going to be back in the game, so there's always that. Now my pet peeve tension is the hamstring, the calves, and the foot, because those seem to be the hardest one to get somebody to elasticize and have good range of motion in order to believe that. My wife has dancer feet, because dancer. Do you guys call it dancer feet?
Dancer.
Bow feet is because she's been using heels forever, and her soleus is so tight. And it's gotten better since she's met me and she's worked at it, but in the back of the soleus, right there where it starts with the Achilles tendinitis, she has inflammation. So she thinks it's fat, and I'm like, no, it's inflammation. She feels it's all watery, right? You're gonna feel it's like a spongy.
Exactly. It's like fasciitis, yes, and you'll get some fluid accumulation there. So
yeah. So it's going to feel watery. That's one sign of inflammation. Okay, that's awesome. Yeah.
And then orthotics too. We'll have patients, we'll try not necessarily at first line, what's called custom fitted orthotics that's specifically designed for their foot. But usually with plantar fasciitis is overpronation. So you're basically walking more inwards. So an orthotic that they can have from the office or different companies will help for Correctives to try to restore balance in the foot. And for both feet, as I know some patients will be like, oh, but I'm having fasciitis only on this foot. It's like, no, you wear both to correct and to prevent any abnormalities.
And if somebody has excessive plantar flexion, like from the tension from the soleus and the gastrocnemius and the foot, of course, goes with it, do you get a custom shoe that basically is the opposite of a heel, that just brings the front of the foot higher and then the heel down? Is there like that makes you walk
some
like that?
Yeah, so we have to see like the different aspects, like the forefoot, the front of the foot, the rear foot, the back of the foot. So in the most severe cases, we have to either do casting or use 3D printing, scanning rather, for custom fitted orthotics. Otherwise, we can get away with accommodative orthotics, which means it can accommodate the average person's foot. For instance, I know it's all marketing, like the ones on from you go to Walgreens, like Dr. Scholl's and that scanner there. It's not
good.
No, it's not accurate at all.
It's like over the counter medicine.
Yeah, but that kind of it's more marketing. Kind of, yeah.
So as a doctor, you can say it out loud.
Yeah, like
we got freedom of speech in this country.
Yeah,
it's a scam.
They're flimsy, and then even those over-the-counter ones that you'll see at the drugstore, they're not the best kind. So if it's something that you're really suffering from and you have the signs that we discussed about, you should see a foot and ankle specialist, a podiatrist.
But they're regular. But let's say they're regular ones that you want to add more cushion to your foot. That's fine. If you don't have a bad foot, no. I'm saying otherwise, average Joe, you want more cushion on your foot.
The shock absorbents or the gel cushion, sure.
Okay.
But if you're having like plantar fasciitis, you need something sturdier, something that's a lot more accommodative, and we can adjust for, okay, do you need more cushioning? And so then not that standard for the average Joe, like as Gabe mentioned, it's not gonna do you good or do you well. So
yeah. Okay, so it's like over-the-counter medicine. It's not gonna cure a very big problem that you need to be overseen.
And you guys are athletes, so you want to get the
real deal.
The real care, yeah.
You want to get the problems out of the way. So you got to go straight to the big leagues.
Yes.
You got to go to the doctor.
Just hey, you're an athlete, so.
Yeah. So we got to take a look at that. Okay. Well, that's awesome. One more question. Okay, so we went over the treatments, we went over this. One big word that I found while I was doing more deeper research, which is one word that we might hear we don't use in the fitness world or in the sports world much. Post-static dyskinesia. What is that? Which is also a problem in the foot.
Yeah, that's basically you're still having pain even upon rest in the foot.
Okay, so it's pain on the foot.
Mm-hmm.
So the pains that you were saying, is it all the ones that we just spoke about, like the pain in the morning when you wake up, tingling from nerves? Is it specifically just for the plantar fasciitis, or it also involves the soleus, the lower leg as well?
It's in the foot, so the plantar fasciitis, and even you'll have that soreness even upon rest. So it's basically, it's worse in the morning, and as athletes,
Is it like a cramp, or is it like from plantar fasciitis?
From the plantar fasciitis, it just means pain in general, like even upon rest. So let's say patients, you'll be running or you're doing physical activity, and that's where it gets triggered and you get a flare up, but that pain is still there. It's like, okay, you know what? I need to stop what I'm doing. I'm gonna finish my workout. Let me just go home and rest. And then hours pass, and you still have that constant. You still have that pain no matter what. So even you're cutting down your activity and you're resting, you're still having that pain and soreness in that area.
Okay, got it. All right, so those are the ones. So going over also something that we also deal in the fitness world, of course, it's obesity. We have problems in the foot from obesity and diabetes. We have peripheral vascular disease, diabetes, which I believe at first start affecting the foot, right? Or
Yeah.
can be.
Yeah, that's so diabetes and obesity are terrible, huge
Terrible.
epidemics in not just our country, but in the world.
In the world right now,
And
yeah.
it's increasing.
Everything
at an alarming
loaded with
rate.
sugar, fake foods.
Yep. Yes, correct. Yeah, and type 2
Excessive
diabetics.
Stress.
State of inflammation, excessive stress.
Yeah.
Absolutely, you're prone to type 2 diabetes.
So how does that work on the foot? Is let's say I saw pictures of peripheral vascular disease in the foot.
Sure.
What would be the first signs of it when somebody who has
Ooh.
diabetes, obese, and sees that? I mean, do you immediately see it in the foot, or do they start feeling something in the
Feeling. Sadly, sometimes it's too late. If you
foot? Do they feel tingling?
if you are a loved one or a diabetic, you should have a podiatrist as one of your routine doctors.
Okay.
Even if you're young or a type 1 insulin dependent diabetic.
So diagnosed with the
You should
diabetes,
see.
immediately get checked.
You
Second one.
should. You know, it's
Okay.
something. Talk to your primary care physician. You know, and not just a pediatric specialist, but also I follow up continuous with your eye doctor as well. Diabetes is so terrible that it does affect, you know, it affects your eyes, your kidneys, and then you have what's called peripheral neuropathy, which is a disorder of your autonomic nervous system, and that ties with the numbness and tingling that you'll have in your feet, sometimes in your fingers. And basically you have a loss of sensation, loss of protective sensation.
In the foot and the hands.
So literally you have no sensation in your feet, and not pretend, but just imagine, some people are like, oh, well, that's a blessing. No, not really.
No, not at all.
You're
No.
walking and
We just
you
spoke
step
about the nerves
on
and the anatomical position. If you don't feel
Exactly.
that, you're lost. It's like navigating at night in the ocean without a compass and a GPS. Well, with the stars.
Exactly.
You know, without a compass and the stars. You know.
You
say GPS today, but you know, back in the day, you had stars only.
Absolutely. Yeah.
Yeah. So
You step on something, on a needle or something, and that's very common.
you won't feel it. A
You won't
needle.
feel it. Nope.
All right.
A big pebble or anything, so you're prone to tissue breakdown, and that's how you get foot ulcers, which is something that we see a lot in our
So if these
diabetic
people
patients.
walk on hot cement in the summertime.
Oh, yes,
they're not gonna
yep,
feel it.
see
They're
it.
gonna get
Yep.
burnt. They're gonna
And we see it.
They're gonna get.
Or on the beach in the sand. I trained in South Florida, in Miami, and we saw that a lot. And it's truly
So
debilitating.
They got the how do you say in English? The burbuja, the bubbles, the water
Yeah.
bubbles from
from second degree burn.
Yeah.
The blisters and
the blisters,
Yep.
Mm-hmm. Spanglish.
Yeah.
Okay, wow. So that's a severe case.
And even with biomechanic involved, let's say in our a normal foot, you know, abnormal biomechanics related to how you walk,
Your gait, yeah,
your
affects
gait
your gait.
cycle. That's what leads to, for instance, pressure points, trigger points, and calluses. So imagine, okay, you know, patients will have calluses, and you know, we study the foot, and even as we correct the orthotics, that'll help correct, so that way they don't have those abnormalities and the callus breakdown. And there are all surgical considerations as well to help rectify that. So imagine, okay, you have normal sensation, you have those painful, you'll develop blisters, you know, from running, or the callus breakdown. But imagine if you don't feel that and you don't know. And over time you're pressuring like friction, it's going to lead to tissue breakdown. And it's going to open up and you have a big open wound.
Mayday.
Yep.
Mayday.
Yeah, and in diabetics it's also with peripheral neuropathy. There's also motor peripheral neuropathy related to your motor muscle.
Motor muscle. Yeah.
Yeah, motor.
Yeah.
Correct. So
So
oftentimes we'll have intrinsic muscular wasting, and that's why you get hammer toes and clawing of the toes.
So you get so it basically just makes the toes
contract more.
Contract
Yep.
like that, like like if they're clawing the floor.
Correct.
And they can't move it; it just sticks there.
Correct.
Okay.
So let's say you put you have your claw toes like that, and these are all more friction points.
Mm-hmm.
So from rubbing from your shoe,
Okay, so you get
and that's what leads
so
to
you get fascia developing here. Okay.
yeah, and then you
What is that
prone
called?
You have intrinsic hammer toe and claw toes.
Hammer toe.
Yep, due to the loss of intrinsic muscle, what is it? Your deep muscles, like what we mentioned before in that layer, that second layer, like your lumbrical muscles, and also your quadratus plantae. But let's say specifically
Quadratus plantae. Say it a little bit louder.
quadratus plantae
Right, there
as well,
you go.
which is yeah. So those muscles
we
get
we want to hear the names of the muscles so we can rehearse and stay sharp.
exactly. So it contracts that intrinsic musculature in your foot are weak from that motor neuropathy. In addition to that, then there's also autonomic neuropathy, and that affects your sweat, for instance. And diabetics are prone to excessive, instead of wet or normal moisture balance, it's complete dryness. So it's called
your skin gets
crispy,
You get like
dry.
psoriasis.
Not psoriatic, but xerosis, and
Xerosis.
there's dryness of your feet, and it leads to
Skin tear, right?
correct. You got
Severe
it.
case.
Fissures, cracked heels,
Blood will come out.
if it's deep enough, yes.
Yeah.
But
your skin cracks and
cracks, and then it's like, oh, I just have nasty looking feet, right? No, it's not just about cosmetics. With that cracking, that fissuring, it serves as a portal entry for bacteria. So yeah, patients will be like, oh, they think it's like fungal feet. No, it can get really bad, and then you have a portal entry for bacteria, microorganisms, and already a diabetic is immunosuppressed. Mix that with already an area of pressure point and callus that gets weakened and small, not smaller, but just larger over time. And it just takes a little hole, boop, something gets in, whether it's a foreign body or a microorganism, and you develop an abscess underneath. So sometimes in the office we're shaving a callus. It's just a callus. But there's fluctuance, there's some warmth, redness, streaking like a red line. Patient is feeling sick, nauseous, vital signs, and we're like, even from the office, and they just look sick. And patients, and oftentimes in the ER and in the hospitals, they have no idea where the source is, and they forget to look at the foot. And bingo, there it is. And even with that,
so it's like
normal callus looking, there is a deep abscess. It is.
It's a parasite. So it's like, okay, so the condition, first you get the tingling, the dryness of the skin gets so severe that the skin cracks, some bleeding, that'll be first sign, right?
No, actually, so they're prone to, that reminds me with peripheral vascular disease. So they have...
they get their skin cracked, and then in the cracks a germ can get in, or any parasite, and then from there it can turn into, it sounds like a flesh-eating bacteria, kind of,
It can happen, yes.
Okay.
I've seen it. Necrotizing fasciitis,
Necrotizing fasciitis.
Yes.
So that's the name of the whole deal. You just so
that's the most severe infestation of it. Thankfully, it doesn't happen. That's more rare. The more common is you have a deep abscess of some sort. It's a staph infection. MRSA is also increasingly common, and often what we have to do for treatment is just drain it. So pretend you have a boil, or like an infected pimple or something of some sort. So we'll drain it.
Do you take the what's inside and take it to a lab for testing?
Yeah, we'll take a culture, and pus comes out. We'll take a swab as well, and some of the tissue that we get, we'll send it to a lab to kind of target your organism, so that way we know which antibiotics are best to treat that infection.
And if it gets that bad, do you carve out the does it get to the point you
get
dead tissue?
Yes.
You carve it out,
tissue, yeah,
and
we have to carve it out. Yeah. So, those patients, they don't have any feeling already. So we can be somewhat aggressive in the office setting, but oftentimes, we have to.
You put some Anesthesia.
Local,
yeah.
You know, they already have no feeling. I mean, you can, but it's not. And if it's an area and infected, it's not. It's not going to do anything. It's going to counteract because it's already the pus is. It's your anesthesia, local anesthesia, is not going to work in that environment.
Yeah.
We try to drain just to stabilize the patient as much as we can, but oftentimes we actually have to take the patient to the operating room for that. And that they have, you know, for instance, general anesthesia or monitor anesthesia care throughout, and we're in a nice, clean, sterile environment. We have to suit and gown up, and we have a scalpel.
It's not a minor surgery. It's
no. It's
full-fledged,
that's why it's called limb salvage. It's a subspecialty within our field because the limb, as your leg and your foot, we're trying to save it.
Yeah.
And also there's also limb salvage. It's life salvage as well because that infection can really manifest and could kill you. The patient could become septic, for instance.
There is I'm not going to say the individual's name. There is an obese person who's working out in my gym that I can see he has special orthopedic custom-made shoes. Mm-hmm. But what I also see from him, from his ankles up, because I have not seen his barefoot, I see in his lower leg, primarily the whole area of the soleus of the calf is purple.
Okay.
What is that?
So that is probably
he's very
yes. It's more of I suspect it's a venous insufficiency. Mm-hmm. So that purplish discoloring. It's called hemosiderin deposition.
What?
Hemosiderin deposition.
Uh-huh.
So a patient with venous insufficiency problems with their veins per se, the blood is not circulating. Oxygenated blood is not circulating back to the heart, and they're prone to swelling and edema. So it looks like a fat leg. Which, yes, it is, but it's because of all that tissue, interstitial fluid tissue buildup, because of the vein valve incompetence.
Yeah.
So it's a whole pooling that's there. So they need compression is the gold standard treatment.
But do they get the compression in that area or other areas of the leg to squeeze blood in there, to flush?
From the bottom of the foot all the way, they should have compression to below the knee. Mm-hmm. I've seen some
from the bottom all the way to the knee.
Yeah. Okay. Sometimes in the most severe cases, even up to the thigh as well. Mm-hmm. And this is something. I mean, there's so much. I mean, this is great. So thank you for all these questions. Venous insufficiency is something that patients have. It's not looked at as often. So if you have signs of the spider veins or what we call reticular veins and telangiectasias, varicosities are like the more thickened, purple veins. I know, yes, I get it. It's a cosmetic concern, but
sometimes no.
This is a warning sign.
But that also affects. And I've had clients like this that it usually comes also. The excuse me, say the name again. I just
the varicosities.
The varicosities happens in a severe case in the feet that the person doesn't get the circulation in there. Now it also happens for cosmetic reasons, yes, but that those veins you need to get checked because if you work out, you're not getting the blood in the legs. And it's happened to 2 of my clients that got the laser treatment for it. And
yes.
Yeah, they're good thing there's laser treatment. Back in the day, my mom got it, and there were injections, and they sucked.
Yeah,
now they're laser
sclerotherapy.
Yeah,
for the.
I'm looking into it, but it didn't progress because what I did is foam roll more. But one of the causes also happens with age, and also it happens with active people because. Age and active people. So if you squat a lot and you deadlift a lot, you do a lot of heavy lifting, that comes at a certain age. Usually in the 30s, you start seeing the veins pop out just a little bit. And that's a sign that it's coming. So once it gets bad, you feel excessive soreness. You start feeling
your legs feel heavy. So
But
these
that's
are
like
all
bad, but
early signs.
early
Yep.
signs are, but for people who work out, you'll start feeling that for some reason your legs are taking longer than usual to recover.
Yes.
Because of course you're not getting blood in there, you're not getting the new oxygen, you're not getting the nutrients, so you're not giving what the muscle needs to recover itself, to regenerate itself. So, in not a severe case, you start feeling that soreness takes a little bit longer, and if it continues, you're like, damn, last year I was lifting and I felt that my legs were getting recovered faster, and then now this year and then the other year you feel like it's getting worse and worse. And a lot of people think it's like, oh, I'm getting old. No, it's the blood that's not getting in there, so you gotta get that checked. Now there's laser treatment, so it's no needles, man. It's just sit there and
Yeah, there are ablation procedures.
Yeah.
One of our best friends.
For cosmetic, wait, one little thing about that. For cosmetic reasons, the insurance will not cover it. Your medical insurance will not cover it. Because, it's like getting plastic surgery. They'll see it, okay, you don't need it. Now, when it gets very sore and a doctor sees you and it says you got it, there the insurance company is going to cover it. That's one thing that I've learned from my clients. That's what they said, because they start seeing it, they wanted to get it cosmetically, and then they told them, oh, my insurance will pay it. The insurance said no. So they waited until it got worse. They told them that they were getting that excessive soreness from not recovering. They told that to the doctor, and the doctor said, okay, I'm prescribing it to you. Boom, the insurance covered it, or gives you a discount. Yeah, just a little FYI from how to take care of that and what you might confront when you go see the doctor. If it's not necessary, you're gonna pay it out of pocket. So it might be better if you wait a little bit till it gets bad and then do it. And then that way, I mean, wouldn't that be better if you see that how worse it can get?
Sure.
They can take care of it, the whole thing there.
Yep, and before it gets too late, it's a whole team. We have to work with our vascular surgeon
It gets
friends,
serious.
and it gets there, or an
It gets
endovascular or an interventional specialist to do the proper modalities and techniques to correct for venous insufficiency with reflux. And then, just to also mention again, with the peripheral vascular disease in our diabetics, there's a peripheral arterial disease, which means basically that your circulation is compromised.
Yeah.
And oftentimes, we'll see discoloration of the toes, but even prior to that, what's called intermittent rest pain. So you're having that pain in the leg. It's
When you're just sitting down and not using it.
it's more worse. It's worse at night. So we have to rule out, okay, so if it's worse at night and consistently for months longer, then it could be a sign of rest pain, and that's more of arterial circulation.
Would that pain be, for people who do not feel that, but just so to get an idea of how pain would be, just to have sympathy for that person, know what a human being can go through with that. Would it be similar to when you get a tourniquet in your limbs and the blood doesn't go in and
Yes,
you leave it
and
for
it can
10
be
minutes?
excruciating.
You can't feel your hand.
Yep.
And the tingling.
And it's constant. And for instance, venous disease. What helps the pain? With all that pooling and the swelling, elevation. So you find yourself, oh my gosh, my legs feel heavy, and I'm just going to put them propped up on the couch, and that'll be relieving for them. Patient with peripheral arterial disease, legs down is going to make them feel better, because the compromised blood that they have is getting down to the extremities. So it's opposite from venous disease, and the pain is so excruciating. We know it oftentimes, unfortunately, it's critical limb-threatening ischemia. So it basically means it's to the point that your leg is threatened. There is ischemia with compromised circulation of arterial blood, and it can be so severe you develop gangrene, or after proper testing with the vascular surgeons and your podiatric specialists as well, that amputation is warranted. And I've seen cases where it's so severe and it's too late that it's actually their whole leg that gets amputated. We, as pediatric physicians, we are able to amputate, it's a toe. I know patients or people will be, oh, it's just a toe, but once you lose a toe, you're prone to other toes. It affects your biomechanics as well, and it's also in that aspect, not whether it was related because of an abscess or a foot ulcer, but if it's a sign of vascular insufficiency, well, more work needs to be done, and before losing your toe, it's a sign you could lose your entire leg. And it's either below the knee or above the knee. So,
ouch.
I even saw, even up to the hip. I saw a case that it was that severe.
So,
Yeah.
so like that would be also equivalent to getting frostbite.
Yeah, it's
the frostbite basically is the cold is so severe that your body is the circulation is not getting to that tissue. Okay, so
yeah, and then oftentimes, we treat like frostbite as if it was a burn. It could be some tender. I've seen, I never saw some frostbite down in South Florida, but here, I've seen it
here in Cleveland.
In Cleveland, I have
like somebody with
frostbite.
a frostbite. What are they doing? Working outside or camping or something?
Well, I saw him in the clinic after. I didn't see him in the ER, unfortunately.
Okay.
My other co-fellow, but basically the toes were black, and actually then I saw him for follow-up, and we were able to salvage his toes. So with proper treatment and wound care, we didn't have to do amputation.
So what was the work done? You promoted circulation back into the tissue?
No, not his was. Frostbite was different. It was
Okay.
from the cold. It wasn't from peripheral vascular disease.
Okay.
That's a different.
So, but how do you treat frostbites? I mean, you just let it heal by itself, give antibiotics?
Yep. No, if there's no signs of infection, there's no need for antibiotics. But topical treatment like betadine and keep it dry, and it's which is iodine essentially.
Okay.
And let it demarcate. And then over time you'll have new tissue underneath. So it's a little similar treatment to our gangrene toes.
Betadine is the soap you use before going into surgery. That brown, yellowish,
brown,
orange.
Yep.
Okay, which is a good thing to have at home just in case.
Sure. Yeah.
Actually, I have that in my main first aid kit.
First aid kit.
Yeah, I do have that there with gloves and trauma stuff, and when I go camping, in case some worst case scenario.
There you go.
Okay, one last one. Tarsal tunnel. What is that one? Well, actually, there's two more, but one of the last two is tarsal tunnel. What is that?
So we spoke about that earlier. It's related to the tarsal tunnel syndrome, and it's that area in the inner aspect of your foot, your tarsal tunnel right in your ankle. You have
the
your
calcaneus. On the medial side of the calcaneus.
Of the ankle.
Okay.
And then so you have your posterior tibial artery, your vein, your nerve, and then those tendons that I mentioned earlier. Like flexor hallucis longus, tibialis posterior. So they run along that whole tarsal tunnel area.
So tibialis posterior. Soleus. What else?
No, not the soleus.
Tibialis posterior.
Flexor hallucis longus.
Flexor
digitorum longus.
Flexor digitorum longus. Okay, got it. And goiters, arthritis, or attack. Goit. How do you say it?
Gout.
Gout.
Yeah, goiters.
It's up here. Goiters happens in the thyroid when primarily one of the reasons is when you are an abuser of alcohol, which I don't think you guys are.
Yeah. Well, that's a goit. That's thyroid. You're talking about gout.
Gout, arthritis, or gout attack. So
attack.
That is basically a dysfunction in the joints, primarily in the metatarsals.
It's oftentimes we'll see in the
phalanges?
first metatarsal phalangeal joint with this your big toe joint. You'll have increased redness, warmth, pain there, swelling. Patients with red wine and alcohol and
crystals.
beer. Correct. Hyperuricemia. You have crystals. So those gouty. It's called tophaceous, tophi, T-O-P-H-I. Basically, it's all as those crystals accumulation.
Yeah. So when they take an X-ray or MRI, it appears like crystals, kind of like broken glass particles.
We'll see it.
Call them crystals.
Well, the crystals is more like on the diagnostic aspect of my gosh, on the microscopic level with the crystals. Once we take an aspirate collection of that fluid joint to see, in order to determine if it's okay, if it's a gout crystal, then under the microscope, the lab will see that it's that kind of crystal, and the way it lines up. It's called bifringence, and if it's in a parallel, if there's a unique pattern, then they know it's like a gout. But we have our labs too. Uric acid level would be elevated. We'll see that frequently as well. But it is a clinical disease, meaning that we have to see and assess the patients and their symptoms.
Yeah.
So it's more of a symptomatic type of.
My grandma got that too before she got more severe things before she passed away, and that was it. I remember looking at it.
And then there are medications for it.
Yeah. So it's treated by medication. No surgery needs to be done. It's more like just giving.
Yeah, it's more of like indomethacin, allopurinol, and other. Those are names, for instance. No injections for
just
that.
oral.
Yep.
Creams maybe.
I don't know about creams now.
There is this,
usually the flare-up will be calmed down. There are times that we've taken patients to surgery, and that's because the accumulation of all that tophaceous gout is so severe, and it's already eroded into their bones. So oftentimes we have to open up the patient and just debride, which is a fancy word for getting rid of all that that tophi, and send it to pathology. Yeah.
Okay, that's good. And last one. Sorry, I know I said two, but I forgot one more. Foot ulcers. So how does an ulcer look? You'll see a vein pop out, or with foot ulcers, will they also cause numbness in the foot?
So that's related, we talked about neuropathy earlier, and abnormal biomechanics, and you're prone to developing like a callus or pressure points in your foot. There's a loss of elasticity in that part of the skin, and there's a breakdown. So you'll develop an ulcer. With the whole veins, we won't see that in the foot, but we'll see it in well, not like on the bottom part of the foot, but there are such things as venous leg ulcer. So we'll see that in the veins, and we'll see it even in that tarsal tunnel aspect of medial malleolus, which is that inner aspect of the ankle. We'll often see the ulcer there. So that's a whole other array of, oh my gosh, we can keep going, but venous ulcers versus like an arterial ulcers. But yes, there is such a thing. But I think what you're asking with regards to the foot ulcer, your typical foot ulcer, no, we won't see a vein from there, not there.
Nothing but anything that'll give signs.
But yes, a lot of hyperkeratotic tissue, which is code for excess callus.
Okay.
We'll see wet tissue, what's called maceration around that area.
Like excessive moisture.
Correct.
Which
it's
is
so wet
in the foot, there's not supposed to be that much.
Correct, and in a diabetic, they don't have sweating already, so that's an indication. It's like, well, we already know what's causing this. So you'll have a pinpoint, even underneath that tissue. We'll palpate. It could be soft and spongy. If you do have, we have to rule out, if we suspect an abscess, deep abscess underneath. It could be superficial, hopefully, but sometimes it can be deep.
Deep, you gotta go into real surgery, right?
Yeah. Okay. There's only so
care.
much we can do in the clinic. If it's a matter of life and death, then we have to do something to kind of drain it to stabilize for bacterial sepsis control.
Oh my God, I hate that word.
Yeah.
I hate that word. Sepsis is when dead blood is in your tissue, right?
Yeah. Well, it affects it. Yeah, that's more like necrotic tissue and liquefied tissue as well.
Yeah, but
necrotic, but sepsis is more
sepsis like. From what I know about sepsis, if let's say you have a cut and let's say a deep one, and then let's say you've been days with the gauze on, you let it rot and it might develop sepsis, which is tough, but it can happen.
Yeah.
If you don't, let's say. So basically, your own body is holding dead blood.
Yeah, well, basically, it's a systemic. It's more of a systemic terminology, which means it affects your body as a whole. So, like, you have an elevated white count, you'll have a fever. Sometimes you can get tachycardic as well, which is elevated heart rate. I mentioned the fever, for instance. Your breathing is also abnormal. So those are all signs of, like, you're correct. Yeah.
So
your body is infected.
But what it would be, would sepsis be in this case, would the sepsis be due to dead tissue and blood, I'm thinking it is, from what I understand, like in the skin, or is it basically a virus or a bacteria that develops?
It's usually a bacteria, and what led to it is the wound itself.
Okay.
Okay.
And
so
basically, like rotting the infection, it wasn't healing.
It basically was your portal to become septic in that nature. Yeah.
Because I know that people that get, let's say, a trauma, and it happens a lot to soldiers when they're out in the field, out in the war, in the jungle, and they don't get like real surgical attention on it unless they're either low in supply, it's a bad wound, and of course you're out and about, might get infected. They say that many times that happens. If it gets worse, they have to amputate it. They don't do that anymore, right? Or not much?
Sometimes they have to.
Yeah,
That's
okay.
for sure.
Severe cases,
because in case, like for instance, if it's like anacotizing fasciitis, then before it keeps spreading, then you have to.
You gotta amputate. Okay, got it. All right. Okay, so problems with the foot. Let's go over a little bit of summary. So, obviously, obesity leads to lower leg dysfunctions and problems, which we already discussed. Excessive impact onto the foot leads to plantar fasciitis, which is a common thing that we see on